And is this on? Yeah. Dear colleagues, dear chairman, my name is Johanna Harjola, and the topic of my study is pre-hospital thrombolysis in high-risk pulmonary embolism and the clinical picture and outcome. High-risk pulmonary embolism is the most dangerous complication of venous thromboembolism with high risk of early mortality. PE should be suspected in patients with dyspnea, chest pain, presyncope, syncope, or hemoptysis. High-risk PE is manifested by hypotension, obstructive shock, or cardiac arrest. It requires emergency diagnostic workup upon suspicion and immediate treatment without any unnecessary delay. The primary treatment of choice is reperfusion with systemic thrombolysis. Aim of the study was to assess the prevalence, safety, and outcome of the pre-hospital thrombolysis of suspected PE. It is a retrospective analysis from Helsinki EMS registry and hospital database between years 2007 and through 2019. The inclusion criteria were high-risk PE suspected by EMS, treatment without hospital intravenous thromboembolism, and diagnosis confirmed by in-hospital imaging or in autopsy. The EMS also used ECG and point-of-care ultrasound as the part of the assessment. Then to the results. 22 patients were included in our study. 17 patients had cardiac arrest, and 5 patients had cardiogenic shock as the clinical manifestation. 53% of patients presenting with cardiac arrest upon EMS arrival, and every patient with cardiogenic shock survived to the hospital. The mean time to return of the spontaneous circulation was 35 minutes. 2 patients had major bleeding complications, but none of them were fatal. The in-hospital death rate was 28%. All of the patients discharged alive from the hospital were alive at 1-year follow-up. This table shows you more in detail. As you can see, the mean age was 57 years old. 18% of the patients had clinical history of immobilization and previous VTE, and 9% had clinical history of pneumonia. Furthermore, you can see in these columns, the first one is all the patients, the second one is survived, and the last one is dead. So the most common symptom of clinical symptom on the field was dyspnea, whereas chest pain, syncope, and cardiogenic shock occurred in 1 out of 5 patients. Regarding to onset cardiac arrest, it was observed initially in 5 patients, and 2 out of them survived. After arrival of EMS, 12 patients had cardiac arrest. This picture shows you the outcome of out-hospital and in-hospital, as well as the 3-month survival of patients who were discharged alive from the hospital. So the total number of the patients was 22, where 17 had cardiac arrest. 8 of them died at the scene, and 9 of them were transferred alive to the hospital. In the hospital, 4 of them died, whereas 5 were alive 3 months later on. In cardiogenic shock, none of them died at the scene, and all of the patients were transferred alive to the hospital and were alive in the 3-month follow-up. In conclusion, out-hospital high-risk PE is associated with high mortality, and this small patient series shows that pre-hospital thrombolysis may improve survival, and the benefit seems to overcome the risk of fatal bleeding. However, these findings need to be confirmed in a proper randomized controlled trial. Thank you.
Thank you for this very nice presentation. Now it's time for discussion. Any question from the...
I have one question.
I have one. I guess it could be quite difficult to do the diagnosis of pulmonary embolism out of the hospital in cardiac arrest patients.
Yeah.
How did all the patients were with pulmonary embolism, or perhaps you had some patients that you gave thrombolysis finally were not pulmonary embolism?
No, all of the 22 patients that we had, they were confirmed the diagnosis by, if they died, by autopsy. So all of the patients, that's why our study is so small, because we wanted that all of the patients have the diagnosis of pulmonary embolism.
And how was the diagnosis in this patient that pulmonary embolism out of the hospital?
Out of hospital.
Yes.
You couldn't do out of hospital, but it was confirmed afterwards by the autopsy if they died, or in the hospital by the imaging. But at the scene, there was this kind of findings that we had to make the decision to give the thrombolysis or not. But the findings were made by the vitals and the ultrasound and these kind of things.
Very interesting presentation. I have a question about survivability here. These numbers you're reporting seem to be more than what's reported in the literature for patients who get thrombolysis who are Untitled Chapter or who are arrested. So it's very interesting. Do you have a control group for patients who did not have PE who came in like this?
No, we don't.
Because in prior studies, when they really look at all of this, it seems like it didn't seem to matter whether or not they got lysis in terms of survivability. So it would be interesting to
Yeah.
Thank you. That's interesting.
Thank you.
Another point would be the evaluation of BNP that is considered as stress or right ventricular level. Do you have any data comparing the two groups? How was the BNP as mirroring the right ventricular involvement? Because that was also an hypothesis to see if there is a difference in right ventricular dysfunction.
Yeah, we didn't.
Or NT-proBNP.
Yeah. That's a good point. We could go backwards and look from the patient's laboratory results and that kind of, but we didn't in this. But maybe in the future we can.
If no other question, thank you very much, Johanna.